Good afternoon, everyone. It is my pleasure to welcome you to the February edition of our 2022-2023 Fairbanks Lecture Series in Clinical Ethics. I am Brian Leland. I am the director of the Fairbanks Center for Medical Ethics, and I direct our Clinical Ethics Fellowship Program. It is my pleasure to welcome you to be with us today. A couple of quick announcements before I introduce our speaker and we get started. For anyone who may not be aware, this Friday, which I believe is February 3rd, will be our biennial Fairbanks Center for Medical Ethics Ethics Conference, and that will be held in person only at Hine Hall on the IUPUI campus. And if you haven't had a chance to register yet, don't panic. If you are interested in coming, we can do in-person registration the day of the event as well if you're interested in attending. We also are offering lunch and learn sessions to educate people about our clinical ethics fellowship, and those will be coming up here shortly. One on February 13th, which is a Monday at Methodist Hospital, and then one February 16th, which is Thursday at Riley Hospital for Children. Both of those are from 11 a.m. to 1 p.m., where we'll tell you all about the fellowship if you have an interest in considering to apply. You can find a registration link to that on your evaluation that you'll receive via email tomorrow. We hope that you'll consider joining us. I also want to invite everyone to please text the code on the screen so that they can receive CME for attending our lecture today. And certificates are being sent out approximately 30 days after the lecture. All right, so on to our lecture. As a friendly reminder, this webinar is being recorded and it will be available on our website, fairbankscenter.org, within about 7 days. And by all means, come back and listen to it again. And if you feel compelled, we always invite you to forward the link to your colleagues. Today's lecture is virtual only, so we have a Q&A box available through Zoom for you to post questions, and we will address those at the culmination of the presentation. However, we won't be responding to questions for the most part until this presentation is over. I want to introduce Dr. Edwards, but before I do, I want to make sure I state that he does not have any relevant financial conflicts of interest. You all may recall a few months ago when I had the privilege of giving this lecture and I spoke about a grant-funded study, and a big chunk of that was utilizing a methodology called group concept mapping to frame high-quality care for long length of stay pediatric ICU patients. And Dr. Edwards shared in that project with me and was the pilot, if you will, of the plane for a huge part of this project, which he is going to share with you, that directly relates to the group concept mapping effort that we did, looking at guidelines to help share with people best practices for providing continuity for long length of stay pediatric ICU patients. And we are so excited that he is with us. So without further ado, Dr. Edwards is an Associate Professor of Pediatrics at Columbia University in New York City. He is a health services researcher interested in children with life-limiting complex chronic conditions who require substantial and ongoing medical and community-based care. Broadly, he focuses on how critical illness impacts these medically complex children and how these children then impact intensive care units with the goal of improving patient-centered outcomes. He sees the future of pediatric critical care intertwined with the growing vulnerable population of children with complex chronic conditions. And furthermore, because of their risk of unfavorable outcomes, these children will continue to have high palliative care needs, and then specifically for us, engage in ethics consultation services. Dr. Edwards received an NICHD K23 award to support his research and career development, and actually used it to create a novel decision support booklet for families facing whether or not they're going to initiate chronic mechanical ventilation for children with respiratory failure and life-limiting conditions. Currently, his focus, as I mentioned moments ago, is on continuity strategies to augment the care of patients in our intensive care unit, acknowledging the traditional fragmented nature of pediatric intensive care models that exist today. We are ecstatic to have him. I consider Jeff among my closest colleagues and a dear friend, and can't wait to hear what he has to share with us. So without further ado, I will hand it over to him, and then I will see you all again as he wraps up and we get into the Q&A session. It is all yours, Jeff.
Thank you very much, Brian. I think you should be able to see my slides. Should be on disorder. And we shall begin. Thank you very much for allowing me to be with all of you and spend this time with you. We're going to talk about long stay patients. We actually refer to them as lost patients. That's our acronym for them here. We have our attendees have a lost rounds every Friday to talk about them, to get together. And want to first acknowledge the Lucille Packard Foundation, for which a fair amount of this work was supported. Their generosity made this possible, and I hope to be working with them again sometime. So first of all, our agenda, and that is to address, hopefully briefly, since I know you went over with Dr. Leland, why we should be concerned with patients who have prolonged lengths of stay and the fragmented care we provide them in the ICU. And then also to highlight the continuity strategies that seek to mitigate that fragmented care. In the end, I hope all of you can supply some examples of how usual care models in the PICU can result in fragmented care for these patients, to describe how the three types of continuity can plausibly mitigate this fragmented care, and then to be able to compare and critique the different strategies that provide continuity care to these PICU patients. So first, a little background. So children and young adults with severe chronic illness comprise probably 50% of all tertiary PICU patients in the US. In some PICUs, they probably make up 70% of the patient population. And even though they account for 50% of patients, they actually use 80% of total bed days and make up 80% of costs. Some of these patients have prolonged critical illness and require intensive care unit stays for weeks or months. Hence, we call them sometimes long stay patients. It's important to note that there is no universal definition for a long stay patient. We can find examples where they use greater than 7 days, anywhere upwards of greater than 30 days. The important thing is this is just far more than the mean length of stay for the PICU patients of 2 days. In single site studies, these long stay patients, with those of them who have greater than 28 days, may probably represent less than 5% of all PICU patients, but they utilize upwards of 60% of total bed days. Such utilization can strain PICUs, delay admissions of other critically ill children, and even raise questions of inefficiencies in resource allocation. Importantly, these are also some of the patients where a lot of our, as Brian mentioned, consultations or palliative care and ethics revolve around. The PICU mortality for these patients probably ranges somewhere between 6 and 37%. In single set studies, it's probably for patients in pediatric cardiac intensive units, it's people anecdotally say it's even higher. And this is in contrast to a 2% incidence or mortality for all patients, and about 4% for all patients with just severe, who are regular old patients, not long stay patients, but have severe chronic illness. They also have high rates of adverse events, medication errors, hospital-acquired infections, undernourishment, and pressure injuries. And also these patients and their families are just as susceptible, if not more susceptible, to ICU stress during their admission and afterwards. And this can be because of their long periods of social isolation. They have greater loss of work and income in their families, and just their children's uncertain or unfavorable course. The challenges of caring for these patients is linked to staff moral distress and burnout. So commonly, moral distress is associated with perceptions of futility and questions of quality of life. But in particular, for this patient population, they're associated with lack of continuity and poor communication, leading to perceived poor care for these patients. I think as Brian also mentioned, PICU care is traditionally rotating providers, where providers will be there. For example, myself as an ICU doctor will be there for a week at a time. A nurse will work a shift at a time that's 12 hours. So it can be fragmented when a patient's there for weeks or months. And also our typical mindset is to handle the acute care issues. So if we create kind of a pictorial framework for that, I would argue that these changing providers results in fragmented care. And fragmented care can mean any number of things. So we can have inefficient information sharing or retention. I, as a different provider than the person who was on next the week before, can have different goals, approaches, timelines, and have patient familiarity. Because I'm acute care focused, I might not pay attention to the big picture chronic issues. All these types of things can lead to family frustration, adverse events, delayed decision-making, and ultimately, I would argue, contribute to protracted lengths of stays. Notably, there's probably greater deficiencies for racial and ethnic minorities and non-English speaking families. These groups report more unmet informational needs, less engagement in communication decision-making, and more decisional conflict than white families. Some PICUs have spearheaded practices to address the fragmented care and better meet the needs of their long-stay patients. These primarily try to facilitate informational and management continuity, and some of them also try to highlight relational continuity. The three most common practices, which I'll touch upon, and we'll get into in more detail with some evidence, is primary, or what's sometimes called continuity intensivists, primary nurses, which actually has a long history, and then also reoccurring multidisciplinary team meetings. And I would say that these are all protocolized but versatile ICU team and family support interventions that are meant to augment and not replace usual care. So what is a primary intensivist? A primary intensivist means the same ICU attending, or sometimes fellow, can take this role, remains a constant physician resource for the long-stay patient, their family, and the team across changes in the rotating or supervising on-service intensivists, the ones actually making the decisions. So the primary intensivist is not the personal physician of the long-stay patient, nor should they be dictating daily management unless they're concurrently happen to be the on-service attending. Typical responsibilities will include things like meeting regularly with the long-stay patient and the family, at least weekly often, attending family meetings, and advocating for the patients, both to the family and to the team. Primary nurses is usually a team of PICU nurses that provide much, but not necessarily all, of the bedside care, and likewise serve as resources for the family and team. They're really supposed to take real ownership of the patient. And I would note that what a lot of places do when they have the same nurse, so a nurse is working 2 or 3 days in a row, and they have that nurse take care of the same PICU patient for those consecutive days, while I think that's good care and appropriate, that's not what primary nursing is. So this would be the same team of nurses who repeatedly come back and take care of the same patient. Recurring team meetings. This is when long-stay patients and their are discussed, especially their medical, ethical, psychosocial complexities. And it's discussed with all available intensivists, those who are both on service and off service, and any and all other providers who might be part of their care. One of the secondary goals and benefits is to create a supportive provider community. And importantly, families do not attend these meetings. And in my mind, Riley's Children's Hospital and Dr. Leland and his colleagues, they kind of are in the forefront of reoccurring team meetings, and I'll be commenting on their findings later on. So if we go back to our pictorial display to fragmented care, what I'd like to offer is that these three continuity strategies actually can have influence and impact on the various aspects of fragmented care, as you see there. Sometimes they can have an impact on more than one. And in the end, I would offer that they improve these adverse events in aspects of fragmented care, and even perhaps decrease our length of stay. I should mention that there are other potential practices that can augment continuity for a long stay patient in the PICU. Those include consultants. So, these patients will commonly have multiple consultants who help take care of them. And some of them are more than capable of providing some level of continuity of care for them. Also, some PICUs employ what are sometimes called navigators. So this is a patient family support person who is there to help them interpret what's going on with their child, to ask questions, and to process things. The thing is, I would say that many of our consultants are organ-based, compartmentalized. So, for example, the transplant team is going to be more interested in the transplant as opposed to maybe what the PICU is supposed to be interested in, is that the whole patient. These consultants rotate just like ICU providers, so they have the same limitation there. And not all patients will have consultants. And there's also evidence, so we could say, well, what about palliative care being the source of continuity for these patients, or even a complex care service? Well, there's actually evidence that there's variation of palliative care across different chronic conditions, with patients that have static encephalopathy and other disorders that are not progressive being less likely to receive palliative care. And I think complex care overall has less of a robust presence in many hospitals compared to palliative care. PICU navigators, I think, are a great idea, but they do require kind of additional personnel who are actually extrinsic to the PICU team. So before we go a little bit further about the evidence of these practices, it'd probably be good to kind of share how common they are used. And there is some information about that we have. So recently, I was fortunate enough to be a part of a survey where we looked at these practices of primary intensivists and primary nurses across 72 PICUs that have accredited PICU fellowships. So these would be big academic centers who would commonly have patients with severe chronic illness and therefore long stay patients. And we asked one senior physician and one senior nurse at each of these sites if their PICUs utilize primary practices, and if they did, how they work and their impressions on their benefits and downsides. So as far as the physicians, we had a 93% response rate, and we found that 24 of these 72 sites utilize primary intensivists. For nurses, slightly less response rate at 82%, and we found out that 30% of them utilize primary nurses. Only 13% utilize both, though. So they do have kind of similar criteria for who gets a primary intensivist or primary nurse. Normally, it's a prolonged length of stay, but they'll also decide if the patient's just complex. And then about half of them will allow the family to request primary or primaries, or the medical team, someone on the medical team can just say, we think this patient needs one. There is some interesting information that even though these places will have this service, a lot of them don't provide it to all the eligible patients. So even though they might have long stay patients who meet their criteria, not every one of them is receiving a primary intensivist or receiving primary nurses. The responsibilities kind of overlap in many of these places. So they commonly expected to attend family meetings, to facilitate the passing of information across the rotating providers, facilitate decision-making. The attendings are requested to visit with the family weekly or regularly, be available upon request. And then the nurses are as the definition of primary nursing, provide consistent bedside care. And we ask these participants to comment on what they believe the benefits of these practices are. You'll see them there in decreasing order. Importantly, we should mention that, you know, these perspectives are from one intensivist and one nurse at each site. So we certainly can't say that this is how the field of pediatric intensive care feels in general. But they said that these practices increase family satisfaction, can reduce stress, can improve communication. As you go farther down, less so benefits for decreasing medical errors and reducing length of stay. We should mention that there are associated burdens or downsides to these practices, and these will come up again. These surveyors commented that it can be stressful for the primary intensivist or primary nurse. It was perhaps more commonly stressful for the nurses. They're the ones who are in the bedside for 12 hours at a time. It can be onerous in terms of their time and effort. People believe that having a primary intensivist means that the team defers decisions to them, which normally they wouldn't, or that the family refuses to makes a decision without the input of the primary intensivist. And then also, the senior nurses felt that having primary nursing can decrease staffing flexibility, meaning if the same nurse is put on with the same patient every time she works, then that decreases the pool of nurses to be assigning other patients, or, for example, making charge nurse assignments and the like. We did ask these places about other things they do for continuity. We asked them about their multidisciplinary meetings, and we found that 22 sites had meetings to discuss long stay patients and often other patients. So it's sometimes not devoted just to long stay patients. Less so than the model set up at Riley Children is their, off-service attendings are mostly, but not always coming. On-service nurses are less frequently coming, and there's less representations of other services such as palliative care. The purpose of these meetings are, of course, to improve information continuity, facilitate decision-making, and other similar things to the primary intensivists and nurses. So next, I'd like to transition and giving you some of the evidence on the actual impact of these practices. And what I'm going to present is pretty much all there is. We are in the infancy of actually studying these practices. So I hope in some days we actually have more evidence for them. The evidence starts back in 2012 with a paper published out of Children's Arkansas. And this is where a single-centered retrospective study of a chronic cardiac care team. And this team would look out for their patients who were in the cardiac intensive care unit for 6 weeks or more. The study included 68 of these patients. It was a pre and post study where they surveyed families and nurses. And what they found was the cardiac care team resulted in improved ability to participate in the plan of care for families and a better relationship with the staff. For the nurses, they found an improved understanding of the patient's problems, improved working relationships with the families, and improved team communication. Next, in 2013, was a study out of Boston where they looked at the effect of continuity of nursing care. So this wasn't particularly about primary nursing. Rather, this was a single-centered retrospective study of 332 patients. And basically, they took all patients with PICU lengths of stays greater than 2.5 days who survived to discharge. And this was over 7 years, but they excluded lots of patients. They excluded patients with incomplete data, patients who were not in both the data sets they were using. So 330 patients over 7 years is actually a pretty small representation of probably all the patients they had. The data was collected 7 times during the study period, and it looked back at the patient 7 days before those data collection times. And what they found was that sicker patients were more likely to receive more continuity. And in this case, continuity was associated with longer PICU stays and more ventilator days. Continuity was, however, associated with fewer nurse-sensitive adverse events. And then we get into the peace rounds. So peace rounds are at Riley Children's Hospital. This is a paper that they published in 2017. I refer to it often. It is their single-centered pre and post study of their weekly multidisciplinary team meetings for their long-stay patients. And they looked at a pre and post study over a 1-year period, examining 60 long-stay patients in an intervention group and 66 historical controls. And what they found was after peace rounds, there was a decrease in the severity adjusted length of stay, an increase in the code status changes from basically no restriction on a intensive measures at the end of life to increased DNR orders at the end of life. There was an improved team members' ability to communicate with the patient and family and other team members, but they just found no difference in overall chronic moral distress for physicians and no difference in chronic overall moral distress in the nurses. However, there was some items in their scale that they used for moral distress that were lower after the peace rounds were initiated. Next is a study out of Wake Forest. It was a quality improvement project to enhance collaboration and continuity. It too was a reoccurring multidisciplinary team approach for which they would discuss their long-stay patients in the NICU. 1 year after implementing their team meetings, they actually showed a decrease in their mean length of stay, a decrease in their readmission rate, and but no change in the parent satisfaction scores. Again, another NICU study. This study was actually a multi-center study looking at about 6,000 patients and the association between a neonatologist continuity and outcomes. So they found that after adjusting for length of stay, gestational age, birth weight, surgical intervention, ventilator days, and finally mortality, they found no association between staffing models with fewer or more transitions and their outcomes of ventilator duration, oxygen use at discharge, or infections. And then we skip to more recently, and when this is kind of when I kind of got involved in the research. I was fortunate enough to be a part of a group that looked at a multi-centered cohort. We looked at 64 PICUs, about 30,000 patients, long-stay patients with greater than 10 days. And we compared patients cared for in units that utilize primary intensivists and or nurses and those units that did not. Importantly, the data did not allow us to say whether or not the patients actually received these primary providers or not, just whether or not the units use those practices. And we found here, we get a little information about the prevalence, and that is about half of the units in this cohort do not have any sort of continuity practice or primary practice. That meaning about half the patients were not eligible for them. More commonly, primary nurses were utilized, and then sometimes about 20% patients could be eligible for both. And so these were the findings. So for those that were in units that just utilized primary intensivists, there was actually about a 10% greater mean length of stay. For those that utilized primary nurses, there was about a 9% lower mean length of stay. And those that utilized both had about a 10% lower mean length of stay compared to patients who were in ICUs that didn't have any primary practices. Importantly, this controlled for number of complex care conditions, severity of illness, patient factors, demographics, and some limited institutional factors. However, if we go a little deeper, we actually asked the sites to estimate the proportions of patients that actually got primaries. So we said, do you use it a little, meaning less than 25% or abouts, for some, meaning somewhere in the middle, or for most of your patients, meaning greater than 75%. And so with this, we looked at primary practices for if they had used primary intensivists for more than just a few of their patients, were found that this practice was associated with about a 12% lower mean length of stay. There were some secondary outcomes which you looked at, which I think are important. So the study found higher proportions of long stay patients who were in units that use primary intensivists had orders to limit aggressive interventions compared to those that were not. So 10% versus about 4 to 6%. We also found that higher proportions of those patients that died in units where they could be eligible for primary intensivists had aggressive interventions withdrawn at the end of life compared to patients that were not. So 75% versus about 65%. Next, we'll transition into the first randomized controlled trial. And this comes out of CHOP. And what they did is they had a single center unblinded trial of what they call continuity care intensivists versus usual care for 115 long stay patients who were in the ICU for 14 days or more. And importantly, basically, these 115 patients represented 63% of all eligible long stay patients. So they asked families if they want to participate, and 37% were either somehow excluded or declined participation. The study found no association between the intervention and PICU length of stay. They had a non-significant 3-day lower mean length of stay, nor was there any association with other outcomes. So hospital length of stay, days of mechanical ventilation, and also parental outcomes. They did HAD scores, which measures anxiety and depression, communication assessment, or satisfaction with decision-making. Importantly, they asked the people who participated or the providers that were with them when this study was ongoing, and they got their opinions on a couple things, and I'll highlight a few here. So they asked them, did you feel that having these continuity intensivists resulted in more efficient decisions? And the majority was they agreed or strongly disagreed with that statement, or that they did make them more efficient. Asked them, should the practice be continued after the trial? And again, the majority was in favor. And then we get into kind of the downsides. We asked, was there a burden of time associated with the practice? And this is more split, where some people did associate a burden with this practice, and whether or not it's not worth it, the majority said declined to say this practice was not worth the time and effort. And then finally, the study that we did here, we did a single-centered, partially blinded randomized control trial of both combined intervention of primary intensivists and nurses versus usual care for 200 patients with lengths of stay greater than 10 days. Importantly, compared to the CHOP study, we actually obtained a waiver of consent. So patients and families were not informed of or consented to the trial. And the reason why we did this is to ensure we could collect, enroll all the patients and collect outcome data from all of them. And then also it allowed us to perhaps reduce our risk of bias when we asked them about their satisfaction with care later on. So these were our subjects. The majority is about evenly split between male and gender. The ages were basically the same. The functional status scale, which is a measure of their functionality, is basically the same, and as was their admission severity of illness scores. So suggesting these are the two groups were appropriately randomized. Our primary outcome was length of stay. So because length of stay is quite rightward skewed, we transformed it using a logarithmic transformation. And we found that there was no statistical difference between the two groups in the length of stay. There's about a 4.5 day non-significant difference. I would like to pause a little bit and just mention why length of stay, like why this outcome compared to other ones. And I think the reason why this is the most common outcome studied for continuity practice is it's considered a ICU quality process measure. It's measurable. It's kind of the culmination of all the consequences of those multiple manifestations of fragmented care that I showed before. And then I would also argue that it's important to families and providers and administrators. And when Brian and I asked those families and asked providers, what are the most important outcomes to kind of measure in regards to continuity practices, length of stay was the fourth amongst all of them. So this is the same outcome data I presented, but in graphical form. So we have in the dotted line are the patients that received the primary providers, and the blue line is the usual care. And so, you look at this and you say, well, they're not that far different. And granted, they were not statistically different. But again, when we consider that the mean length of stay for a PICU patient is 2 days, and their median length of stay for the average PICU patient is 3 to 4 days. Some of these spaces between these two lines, we're talking about perhaps 5-10 days, which could be, relevant to a family and to an ICU. And of course, we looked at multiple secondary outcomes. We looked at duration of invasive mechanical ventilation. There was no difference there. We looked at unplanned intubations. There was a seemingly difference between the usual care and primary group, with the primary group having less unplanned intubations, and no difference in unplanned readmissions. I should mention that for these secondary outcomes, that the study was not powered to really detect a significant difference between these two. So these should be taken with a grain of salt. There were some patients that underwent tracheotomy, and the time to trach was not statistically different between the two groups. There were 14 deaths in both groups. Those patients who had primary intensivists and primary nurses, they were more likely to pass away with the DNR in place. And then finally, some other secondary outcomes, adverse events, hospital-acquired infections, and involvement of patient care services for grievances or complaints. Those were no difference between the two groups. Well, at the same time, besides just collecting the clinical data, we also went out of our way to ask parents and providers what they thought about their care and about these practices. So peri-discharge, families were asked to fill out a 2-page survey. On one page was 7 statements about their PICU doctors, on the other side, 9 statements about their PICU nurses. And they were statements they had to agree with. I'll give you an example. So the questions read something to, many of them read as a group. So for example, as a group, the PICU nurses helped me participate in my child's care. The fact that different PICU nurses cared for my child was a problem, and they would agree or disagree with these statements. About 70% of the families participated. Some of them were excluded because they were non-English reading. And just to put these up as a gestalt to kind of see the difference, we found differences between the two groups, meaning the groups of families that had their child receive just usual care versus receiving primaries. So there was statistical difference when we asked about their questions being answered thoroughly in a way they could understand, whether or not their opinions and concerns were listened to. So if you see here, the top bars being concerning asking this question about the MDs, the bottom bars being about the nurses, the top lines at each side, each of the boxes being usual care, the bottom being primaries. Helping the parent make medical decisions. The fact that the doctors change every week was a problem. This would be the reverse. So if there's more red in this one, that would be showing that the intervention is making a difference. And again, we found that in the primary group. There was, as you can see with these graphs, there's kind of a ceiling effect where people generally feel positive about the care they receive in the PICU. And this kind of influences or affects how likely you are to find a difference. Again, they're very satisfied, so they weren't more satisfied in general but with having primary nurses than not having primary nurses. Also, there was no difference in how well they knew the teams knew their child, how well they kept them informed about their child's condition, or how well the nurses incorporated their recommendations into the care of their child. In regards to the providers and their opinions, we asked nurses, tendings, and fellows. Importantly, one of the questions we asked them was, did they think that some of the patients in the usual care group should have had a primary nurse or primary intensivist? And the majority of them could think of a patient that they thought would have benefited from those. And then we asked them kind of how beneficial they thought primaries were. Again, largely beneficial. It does vary by the role the provider takes. And then actually, again, going back to the survey of the senior nurses and senior intensivists at the 72 institutions, we asked them about things like, is being a primary emotionally or mentally stressful? And we do have some quite a few that are saying at least occasionally these practices are stressful. What about burdensome in terms of time and effort? Again, the vast majority will say that these practices are occasionally or often burdensome. And then also a question about decreasing staffing flexibility. So a number of closing thoughts before some questions. So the numbers, I would say the numbers and complexity of our PICU patients will continue to grow. This has been the trend. There shows no sign of changing. Again, as Brian mentioned, I do believe the future of our field is intertwined and will continue to be with this type of patients. The fragmented care that we provide with our rotating care models do not meet the needs of our long-stay patients and their families, and it can actually have negative implications for the providers. These continuity practices may provide a means to better meet their needs and improve patient-centered outcomes. Importantly, perhaps a third to a half of tertiary PICUs have a continuity strategy for a long-stay patient, but these practices are not uncommonly ad hoc or under-resourced. And this is, we have evidence of this by that many eligible long-stay patients, both in the survey and in the retrospective multi-center cohort study, don't necessarily get the continuity strategy for which they're eligible for. So this is important because when not all eligible patients receive continuity, when a practice is ad hoc or when providers only self-direct volunteer to be a primary or such, bias can play a role in which patients receive continuity. So for example, patients or families perceived or labeled as difficult or challenging are probably less likely to receive continuity. Relatedly, some PICUs honor team member or family member requests as a trigger for providing continuity. Again, team member requests may be biased towards liked patients and against those who are perceived as difficult or challenging. Doubtless, families with high health literacy or who are English proficient or are from a non-marginalized groups probably disproportionately request primaries. So collectively, these deficiencies risk exacerbating disparities that already exist in our healthcare practice. And I think they argue for having standardized eligibility criteria and consistent provision of continuity strategies, even if we have to make prioritization schemes and have to somehow triage these continuity strategies. There is some evidence that these continuity strategies decrease length of stay, that they improve perceptions of several aspects of care for the long stay patient, and that they result in less intensive interventions at the end of life. However, they do require additional effort in terms of time and emotion and have other downsides compared to just usual care. So I do think more widespread institutional adoption and individual buy-in for these practices necessitates greater certainty of their benefits. So I would offer that means we should be going out of our way to have additional studies for both their benefits and the burdens. And I would offer this means the need for a multi-centered randomized control trial. And then finally, I would say that PICU continuity is the responsibility of PICU providers, and that continuity provided by the PICU itself has certain advantages over other extrinsic consultants or parties providing that continuity care. So with that, I just want to leave time for questions and give my thanks to all the patients, families, and providers that participated in all this research, my institution, and then my funders over the years. And with that, some questions.
Wonderful, Dr. Edwards. That was magnificent. I appreciate, the incredible level of detail explaining the phenomenon and what evidence does exist. We have a few questions in the chat box that I'm hoping you might be willing to speak to. I think one is something that you touched on, but maybe we could explore it a little bit further, which the question focused on challenges surrounding certain personalities being better equipped to serve in the role of a primary intensivist, for example, and how to navigate the complexities of only a small percentage of, for example, a division's faculty being willing to volunteer, participate in that model, and how to try to establish an equitable approach so that there isn't an undue burden on a small percentage of the faculty.
I think it's a great and very realistic question. I think the role does draw certain people to it more than others. I do think that when you commonly describe the role to many intensivists, their first inclination to be like, that's not why I got into this field. And that's maybe a little bit different than to say they're not suited for the role or not more than capable for the role. I think the vast majority of providers their hearts are in the right place. They know how to communicate well. They have their best interests of their patients in mind. But in order to have a robust program where you're actually providing continuity to the majority of patients that need it, you have to have a fair amount of the nursing or attending pool being able to contribute. So that probably 50% need to be willing to say it's worthwhile. I think it's possible to sell the role by making it clear that, for the vast majority of patients, I think the role is not onerous. I think if you do it long enough and with a number of patients, you will come across an instance where the situation is particularly challenging for all involved, and those tend to be memorable. So everyone should be prepared for that, but understand that's probably not the norm.
Appreciate your insights on that. I think there's a question that I think relates directly to this, or at least tangentially, which is you put up a couple slides from your survey study communicating perspective or impression of the level of burden of serving in this capacity. And I'm wondering, is there any information or data that speaks to whether that perceived burden directly relates to the fact that so infrequently is this set of responsibilities incorporated or acknowledged as some part of someone's FTE specifically, meaning their full-time equivalent, rather than it simply being and do this in addition to what you're already doing. And if there was a dedicated effort to acknowledge the value that comes with this model and dedicating time for individuals to serve in that capacity, would that mitigate the perception of the additional burden that some communicated?
I think it's a fine idea to reward or compensate a provider that's doing quite a bit of this. So, and I've spoken to a few people across the country who, out of the goodness of their hearts, will take on multiple primary patients. And not one of them have I met where their division chief or chair will commit a certain amount of their FTE towards this. So it's a topic of conversation. And I think it would be appropriate for someone who really does make it a part of their professional practice to take on this role. That being said, I don't think that's going to happen either until we have the more data and evidence to show the benefit and how it improves things in a way that a division chief or chair could get behind and say, yes, this is worth money, as opposed to this is just a good family-centered care and we should probably do it just out of the goodness of our hearts.
Thanks for sharing that. There is a question that inquires about whether these models have any impact on conflict between physicians within the medical team with pertaining specifically to treatment or end-of-life decision-making. I know at Riley, one of the focal pieces of Peace Rounds is an effort to ensure that the medical team can coordinate and be aligned in the information that's communicated to a family in order to try to mitigate confusion, for example, for a family feeling like they're getting different avenues of information that seem to potentially conflict with one another. Wondered if you might be able to speak to that at all.
So it's kind of a understood phenomenon that, you know, the two parties, not everyone's always of the same mind, that there would be disagreement or conflict between the PICU team and the primary intensivist regarding management. We asked this of the one senior physician, one senior nurse. It was actually relatively uncommon. 50% said it never happened, and 50% said it occasionally happened. So I think it probably does, and when it does, it's probably memorable. But it's usually, I would imagine, fairly uncommon.
There is an interesting question here about the role of continuity and whether advanced practice providers are in a position to serve in that capacity. I think, you know, certainly at Riley Hospital, there is a growing effort to strengthen our advanced practice provider representation in our intensive care unit clinician group, and I could see lots of reasons that they might be, you know, really effective serving in a role as a continuity primary. Didn't know if there was any information or literature data about that to this point.
I think it's a great research idea and topic that needs to be addressed. There is no research out there on frontline providers like nurse practitioners or physician assistants doing this. I work in an ICU that has residents, so they change every 4 weeks. So that's not really optimal. When we did the study here, the nurse practitioners on another floor were very appropriately vocal, saying, well, why can't we do primaries? And one of the reasons why we didn't do that is because we know that every single PICU should have a, physician nurse dyad at least. So it's a model that should be could be adopted in pretty much any PICU. But I'm all for PICU continuities that's provided by PICU providers themselves.
Great. I have one closing question, unless another additional ones pop into the question and answer box, and that surrounds, and I think you touched on it in your lecture, the concept that units adopting a primary intensivist model, that it's important to reinforce that the continuity intensivist is not meant to be making all of the day-to-day management plans. And I think that is great to communicate in theory or as a recommendation, but as a family becomes, identifies, the longevity of their care with a specific provider, it isn't outside the realm of possibility to say families refuse to make many decisions without the input of that individual. And I wondered if you could speak to what it might look like to navigate the complexities of continuing to move a patient's care forward on a day-to-day basis without requiring, absolute input from the primary intensivist, even as often as daily.
Yeah, I think it's a risk that could happen, that the lines of responsibilities can be blurred. I think there are certain things that if we establish them from the outset can help with that. For example, if a family requests to speak with their primary intensivist, then that request I would recommend should go through the PICU team, right? They have to communicate with the PICU team to say, I'd like to speak to my primary intensivist, as opposed to them just using the cell phone or email of their primary intensivist reaching out directly. I think those kind of separations can help. In family meetings, I personally think that the on-service intensivist should be the one leading the conversation, speaking perhaps the most, giving any kind of new diagnostic or prognostic information during those meetings and elsewhere. So while just like with all these kinds of, while it's good to be versatile, these kind of interventions, they will run into like situations are different. Things will not necessarily go as they planned. But I think overall, for the vast majority of cases, I think it wouldn't get out of hand.
While you were speaking, there was one final question that popped up, and I thought it was an interesting one. So maybe we'll close with this. And the question inquires about in your intensive care unit at Columbia, if respiratory therapists are unit specific, and if so, has there been consideration or exploration for some level of a role in this continuity process for respiratory therapists?
In my unit, we actually have a shortage of respiratory therapists right now, so it's not possible and conceivable. But if that were to happen someday, I would more than welcome it.
Outstanding. Well, it is 12:59. You are right on the nose. We cannot thank you enough for coming to speak with us today and sharing your insights and your expertise. An absolute pleasure to have you, and I think wonderful to kind of see the evolution of our group concept mapping effort, and the intention of framing high quality care for the long length of stay patients as we think about how to honor those domains of high quality care within the respective continuity strategies. I suspect that your email address is going to be available to people, and this lecture again will be recorded and available on our website. Thank you to everyone who joined us today, and you are dismissed. And thanks again, Dr. Edwards.
Bye-bye.